want to see your happy face. I want to see a smiley, a land that's full of jolly. I'm ready to go.
I have been given the honor to introduce you, and I just feel so privileged to do that. Let you all know what she means to me, to the pharmacy community, to her patients, the type of person she is. In fact, I told her that she really needs to come to Nigeria, and we have to just adopt her as a Nigerian, you know.
I'm going to share my screen. Dr. Pounds has asked me to give my thoughts and insights as to how nutrition intersects with HIV care. So again, I want to share how these two approaches intersect and how nutrition plays a huge role in the outcomes of people who are living with HIV, and to discuss how we can integrate this service in a resource-efficient manner. So the overview is essentially that, to speak about how nutrition impacts health outcomes generally speaking, but then how it specifically impacts the outcomes of people who are living with HIV. I want to discuss ways that we can integrate clinical nutrition in a protocol-based fashion. Recording in progress. For persons who are living with HIV, and then discuss how we can collaborate in ways that we're even doing in the moment to bring resources together and integrate nutrition soundly into the care of persons living with HIV. My disclosures are, I'm a speaker for a few different companies, most notably for persons living status, with desire for persons living with HIV. So a balanced diet, maintaining a healthy weight, supplementing micronutrients, all this is beneficial, but it also can ways of doing this with the use of a simple measurement tape. So incorporating anthropometrics into the care of people who are receiving HIV care. So a simple measurement tape is all it takes to do the job. So with the simple use of this, and I consider this a fifth vitals measurement. So we're checking blood pressure, we're checking weight, a simple set of measurements can also give us great insights into the nutritional status of our patients. So it allows us to assess their health status as well as their nutritional status. We're able to personalize care for that individual in that context. And then if there are ways to integrate these measurements and these protocols with technology, then we're really able to build robust protocols and plans for patients that give them their ultimate improvement in their HIV status. So how do we do this? Simply, and I'm sure everyone knows and has incorporated this before, perhaps not always in the context of it being a necessary part of care for people living with HIV, but simple measurement in the middle aspect of the upper arm, and noting what that circumference is. The normal circumference for people who are adult generally falls between 23 and 34 centimeters, although, of course, exact normal measurements, they vary depending on the context, depending on the culture, depending on the individual. But it can generally be assumed that for anyone, male or female, a healthy circumference, that's normal, is anything that exceeds 23.5 centimeters. Things that are below that may indicate that a person is at risk of malnutrition, and then certainly for children or adults, if that circumference. So measuring aids, simple that And then that combined with a food source, a reliable way of. So right now, I'm here in the United States, and Dr. Pounds works with me on a number of projects that we're doing for people living with HIV here in Atlanta. So although the details of how we integrate this may differ between the United States and where you are in Nigeria, there are certain aspects of it that are very similar and that can be replicated anyplace. So in the U.S., our focus may be more on, say, obesity-related issues and metabolic disease, how people can age in a healthy way when living with HIV. It's more dietitian-driven, and our government agency who supports all of these facets of HIV care in the U.S. is our Ryan White funding program. The care is ultimately individualized for that individual patient in front of us.
Nigeria is an endemic area, and in fact, Nigeria has the highest burden of malaria in the world, and South in Nigeria has the highest. And so as you're sitting down there, mosquitoes might be biting you, your legs, or wherever, and then you see people clapping their ears and all that. Now the mosquitoes are very intelligent. If they go to the mortuary, they make their buzzing sound and nothing happens, and they leave because there's no blood. They feel that you are alive. When you hear the sound, you want to quickly catch it and kill it and all that. Then you know that there's blood in here, and also the smell. It has a very strong perception, so it can get blood. So the topic, like I've said, is on the board. So nutrition by definition is the process through which the body acquires and utilizes nutrients for necessary growth, maintenance, immune competence, and resistance to infection. When you have nutrition, it helps in growth and development, recovery, heal. All this has been done. When people are on admission, when they are well nourished, they are discharged on time and they go home. And then they have physiological resilience. When there is nutrition is a clinical determinant, not only a dietary issue. Nutrition shapes the body's capacity to resist, to fight, and to recover from infections. In malaria endemic settings, the child's nutritional status is a clinical significance as the parasite itself. So what we are saying is that a child has malaria infection. You don't just face only treating the malaria, you also look at the nutritional status, because if you don't take care of that, you might be wasting your time because the malaria can end up killing the child. How nutritional deficits affect infection risk discovery and clinical outcomes. We saw in some studies that stunting was about 30.9% in this clinic population. Wasting was all that. We saw that in presentation yesterday. And then vitamin A, about 190 million children globally are affected by vitamin A deficiency and all that, to draw us back to the impact and the outcome of all this is impaired innate defenses. Then there's reduced recovery capacity and worsened clinical outcomes that will lead to severity and impaired response to antimicrobial treatment. So now nutrition and immunity, how nutritional status shapes the body's defense against infection. So the immunity helps you to fight against those viral infections, bacterial infections, and all that. So what is immunity now? By definition, is the body's ability to resist and eliminate infectious agents through coordinated innate and adaptive defense mechanisms. The innate mechanisms are the ones that come first. They are the ones that you are born with. You come down with it. So they are non-specific. They work everywhere. And immediately they respond to whatever infections that is there. So we have the physical barriers, the skin, the mucosal epithelium. We have undercellular macrophages, neutrophils, natural killer cells. Then you have the cytokines, tumor necrosis, alpha, then interferon gamma, interleukin 12. Also, you have fever response as a defense mechanism, and you also have they are first to encounter Plasmodium parasites. While you have the adaptive immunity, which are acquired. For example, we are living in Nigeria, and so mosquitoes have been biting us, so our body has developed immunity to fight those malaria infections. But somebody living in America and somebody living in the Arctic or Antarctica areas where there is no malaria, they don't have adaptive immunity, and so if mosquito bites them, it can even kill them. In the past, we discovered that people died of mosquito bite, and they said a small tiny mosquito killed some persons, and we all heard it. Is there anybody who heard that? Yes. So what happened is that you have adapted to it and you have developed immunity. So this immunity that is acquired are specific. They are slower, but they are more targeted, and they come within days and weeks. We have the T lymphocytes, they are the cellular immunity. We have the B lymphocytes, they are antibody productions, and then we have the immunological memory after exposure. Clinical immunity to malaria develops with repeated exposures. This requires intact nutritional status to function effectively. So specific nutrient immune function relationships. The protein, what does it do? Generally, all the functions. Then when there is a protein energy malnutrition, they are reduced. Vitamin A, what do they do? Mucosal epithelial integrity, T helper cells differentiation, natural killer cells activities, and then now vitamin A deficiency will lead to what? Impaired clinical immunity to malaria. Then you have zinc, and what does it do? Immune signaling, that's what it does. And you see the natural killer cells, cytotoxicity, then interferon gamma production, oxidation burst, killing of the parasite. That's what zinc will do. And then Plasmodium steals zinc from the host when you are not well nourished to produce and to have enough zinc in the body. Then the iron, what does it do? Hematological function, erythropoiesis, zinc helps production of red cells in the body. And then when there is no zinc, what happens? There is an iron paradox in malaria. If a child is having malaria and then you just treat malaria and you don't treat the iron, and you don't give iron to the child, there is a paradox. The reason is that the iron is a nidus for infection, and so the malaria parasite now takes out of it. And so when you're giving malaria, some mothers, every morning they bathe the child, they give iron. Every month they bathe the child, they give the iron. Even when the child is sick, is having malaria, they don't know. They are just giving iron. So they are not treating for malaria, but they are giving iron. It's very dangerous. So if you are in an endemic setting where you know that there will be malaria infection, then you treat for the malaria while giving iron. So nutritional status and immune response, two pathways, adequate versus poor nutrition. When there is adequate nutrition, what happens? There is functional immune response, which leads to effective pathogen control and better clinical outcomes and faster recovery. There is a reduced severity. But when there is poor nutrition, the person does not eat well. His immune systems are dysfunctioned. There is increased susceptibility to infection. It has higher infection frequency. Then disease will now progress, and there will be an increased morbidity and mortality. Next slide. All right. So malaria, mosquito. You can see the mosquito there. I've already introduced it when we're talking about malaria. Applying the nutrition immunity framework to Plasmodium falciparum malaria. We are talking about Plasmodium falciparum malaria because this is an endemic region, and Plasmodium falciparum is the most dangerous because it affects both the young blood cells and the mature blood cells. We have other species that affect only the young blood cells, and we have other ones affect only the matured one, but this one affects both. So now look at the world malaria map. We have those areas that are blue. There are no malaria there. So and those areas, we are looking at Russia, we are looking at Australia, we are looking at, when you come to America, North America, and then we are looking at Chile down there. But that side where Kevin went, Brazil, there are malaria infection there. Where Kevin went to get all those nutrition for us. I remember. So there are malaria infection there, but they are not always. Look at the color there. The blue says malaria transmission is not known to occur in these blue areas. You have the Arctic up north and the Antarctica down. You have Australia there. You have Russia. You have North America, and then you have this Chile. But then the yellow is that malaria transmission occurs in some places, not always. But look at the red. What did they say? Can everybody corrose it? Throughout. And that is why we put mosquito net on our windows. Maybe the net is not enough, so you have to sleep under the net in the bed because mosquito is there throughout. It's either you have waterlogged areas, or you have a stream somewhere, or you have dirty places where they pack things near your house, or the rainy season mosquitoes are there.
I'm standing on behalf of the President, Institute for Dietetics in Nigeria, to extend its warmest greetings and best wishes to the President and founder of WASPEN, Dr. Teresa Pounds, and also the team, participant, delegate to the 2026 WASPEN Clinical Nutrition Conference. We commend WASPEN for its commitment towards advancing clinical nutrition practice across Africa and beyond. The theme for this year, Sustainable Clinical Nutrition Services, ensuring access, safety and collaboration, is timely and relevant, highlighting the need for the resilient nutrition system that promotes quality patient care through multidisciplinary partnership. As we gather to share knowledge, innovation and best practice, we remain committed to strengthening clinical nutrition services and improving patient outcomes and fostering professional collaboration for sustainable healthcare delivery. The Institute for Dietetics in Nigeria wants to assure WASPEN for its continuous support and collaboration. Also want to appreciate the founder for this beautiful innovation to make sure that the role of dietitians and nutritionists in the healthcare system is being looked into, most especially in the aspect of employment and also services.
So we are going to take on maternal and child nutrition, linking clinical care with self-care for sustainable outcomes. So let's set the tone and talk and have a little discussion around what self-care is. There is a little bit of misconception out there about what self-care actually is. So self-care really just speaks to the ability of individuals, families, or communities to promote health, prevent disease, maintain health, or cope with an illness or disability with or without a healthcare provider. So, promotion of health, prevention of disease, maintaining health,
coping with illness or disability with or without a healthcare program. So I'm going to start with clinical care. So I'm going to ask my panelists very, very quickly to tell us a little bit about what clinical care is, and then we make that connection. So Nurse Sarat.
Thank you so much. For the clinical care concerning self-care in the hospital setting, you have the first point of call are the nurses. And when they come to you, you do a quick assessment. Head-to-toe assessment, vital signs. You carry on with such activities. When you arrive at a conclusive assessment, you move on to the physician, who will in turn reassess that patient and carry on with the process. And nurses use Dorothy Oren self-care deficit in assessing patient, which says that you assist the patient or client in activities of self-care whereby the patient is unable to carry out such activities. That is the guiding principle in nursing.
Okay, thank you very much. As a dietitian, we have our protocol in the clinic, which we call ABCD. We do the nutritional assessment, the biochemical assessment, the clinical assessment, and then the dietary assessment. And usually, like our nurse said, the screening is first done at the nurse's station, and then the patients are referred to the dietitians to carry out this anthropometric assessment and all of that. And then after that, we give our interventions, which are usually individualized. But apart from that, we also do general health counseling, nutritional health talks at the various clinics, the ANC clinic, the infant and welfare clinic, where we tell mothers about how to breastfeed their mother, breast positioning, attachment, and also tell them the importance of breastfeeding their children.
So thank you very much. So let's go very practical here. So if we have a pregnant woman who's come in, you've done the clinical assessment evaluation, and your labs are showing you, for example, that she's anemic. So from a clinical perspective, that's what you come out with. Now let's make that link to self-care. So as a nurse, you have an anemic pregnant woman. So how would you direct her to apply the tenets and principles and pillars of self-care, looking at nutrition as well as some of the other pillars upon which self-care rests? Thank you.
Thank you. In the antenatal clinic, where we come in contact with the pregnant women and a diagnosis of anemia has been made, you will have to talk to the patient, knowing what she knows already about nutrition and the prevention of anemia. For example, we are taught about malaria. We have malaria in pregnancy. That can be a contributing factor. If it is not adequately treated and early enough, it can result to anemia. Then the dietary intake of the woman, you take a brief history of what she takes as breakfast, lunch, and supper. That will guide you to her daily intake of the nutritional balance for the day. So when you have assessed this, that will guide you on how to advise and treat this patient. So in that sense, her hygiene comes to play as well. Her personal and environmental hygiene comes to play. If her hygiene is faulty, the nutrients she's taking in, she will have problems with it. If her environment is unhealthy, for example, she has flies around, she will have issues that will lead her to anemia in pregnancy. So those areas must be taken care of. And you advise her on her hematinics that are prescribed to be taken as prescribed, not when she wants to. Because some women, they are given antenatal hematinics that will help augment their nutrition, and at the end, when they get home, they don't take it as prescribed. So her nutrition, you will stress on adequate carbohydrates, protein, vitamins, minerals, and the micronutrients. Thank you.
Okay, thank you very much. And so as dietitians, we have the core responsibility of tailoring and counseling to adequate nutrition in anemia. And so what we do is to highlight the iron-rich foods that is necessary for the pregnant women, and this include the meat, the intake of fish, and dark green vegetable, vitamin C rich foods, our local grains, and then legumes. And then we go as far as encouraging them on the adequate intake, timely intake, and then also we make them to understand the implications of anemia in pregnancy.
Excellent, thank you very much. So basically, what self-care is not. Self-care is not self-medication. Self-care is being intentional. And as healthcare professionals, we have a responsibility to counsel and direct patients so that there is a continuum between the clinical care and the self-care, so that you end up with positive outcomes. If you have a patient that has a prescription, they've gone through the clinical, done all of that, you issue a prescription and there is no compliance, there's no self-care. So you won't get the positive outcome that you're looking at. So when we talk about self-care, there are 7 pillars. Nutrition is a very key pillar. We have health literacy, we have physical activity, your mental health, rational use of products and services, and I think I left one out, hygiene. Mental health. So all those come into play.
The goals of anybody, especially babies and children, is a very important component that is responsible for immune functions, for endocrine functions, and also what we popularly know as metabolic functions. The gut microbiota is very important in determining how the immune system of an individual develops. And taking care of that gut based on how we feed the child and what we do with the gut, it's very important to know how that immune system develops. Also, the gut is important in programming in early life. What happens to the gut of a child? As I was preparing for this lecture this afternoon, I got a call from the neonatal unit. I have a baby who is a preterm baby whose father is threatening to discharge against medical advice this afternoon. This child had problems with the enterocolitis, and the father was saying, I want to take my baby home, and would not listen to any other member of my team. They contacted me, I had to go there, sit him down and teach him, and I told him I'm going to use you to enhance my lecture this afternoon. The gut of a baby is not just important for digestion of food. It's not just important for growth, it's important for immune function. And if the gut is not, if that is not taken into consideration, that child can develop, the immune system can develop can lead to several mobilities that otherwise would have been prevented. Also, the gut microbiome or the microorganisms that are present in the gut play a lot of critical role in maintaining well-being and health of that child. For instance, babies that are premature, babies that are acidic, their gut plays a vital role on whether the baby will survive at all and how impact that baby will be. We're going to go to the lectures in details. So gut dysbiosis talks about now that there are challenges that affected the gut of the child or the gut of the neonate. How those challenges will lead to mobilities in the neonate. We're going to discuss that as we progress. Next slide. What are we talking about today? Permit me
I'm going to represent my constituency. You know, they talk about that this topic is supposed to be pediatrics and neonatal, but I decided to go with neonatal because I'm a newborn doctor. Clap for me now, clap for me. I'm a newborn doctor, so I'm going to focus a lot on the neonatal cases. So now, who are we talking about? Whose God are we talking about? We're talking about vulnerable neonates. These vulnerable neonates can be extremely preterm babies. And Asaba is a home of prematurity. I can tell you that for a fact. I have colleagues that are from Asaba Specialist Hospital. I have myself, I'm in the FMC Asaba. There is no time you come to the hospital, you will not see at least 5 small babies in our neonatal units. There is no time, it's not possible. There will be 5 to 10 at least in all the neonatal units you have in Asaba. So prematurity is here with us. And these days of IVF, you have prematurity everywhere. So these are the vulnerable neonates we're talking about. These premature babies, what are we going to do with them? How are we going to feed them? We also have very low birth weight babies that will come out maybe between 32 weeks and above. Then we have some other neonatal conditions like respiratory distress, sepsis, asphyxia is there with us. Suffice it to say that our people still go to deliver in where they are not supposed to deliver. So they will come with asphyxia. And asphyxia poses a great risk in terms of how do you feed an asphyxiated child. We're going to discuss that before. They will have some other problems like nephrotic surgical problems on fallacy, gastroschisis, as the case may be. Then these infants are born, I'm back to my zone, they are born with immature organs. They are born with limited stores of energy. Because within the last 3 months or last trimester of pregnancy, that is when the body or the fetus accumulates nutrients. For whatever reason, maybe due to obstetric complication, this premature baby has come out without accumulating nutrients. And the baby will not be able to eat aqua and rice. The baby will not be able to eat as much as the baby can eat. So how do you balance this to get the baby being alive? They have high demands because they need to grow. Some of these babies gain from 28 to 200 grams per week, 30 grams per day. How do you feed them to get this optimized growth? Those are the challenges we are going to discuss. They also have very vulnerable systems. Like I said before, their immune system and all the systems that sustain life is not matured. Next slide. So why nutrition matters in neonatal care? Why does nutrition matter in neonatal care? Is it just food, a source of energy? Adequate nutrition is crucial for development of certain organ systems in the body. Most importantly, brain growth. Now we're talking about the baby that survived. What is the quality of that child that survived? Is he surviving and becoming a doctor like me and like you that is still down here? Or did he survive and become a low-class blue-collar worker? Because if the child is not well fed, especially in the first 1,000 days of his life, it can affect the power or the IQ of that child. Some of us are flogging our children. Why did you come first in class? The reason is because of inadequate what? Inadequate what? Nutrition. That's why I must commend again the visionary behind this conference. Nutrition and its challenges must be addressed for us to attain our growth potentials in life. It's crucial for lung development because the lungs are not developed without appropriate nutrition, immune function, gut maturation, and long-term developmental consequences. This is why we are discussing this topic.
Oh dear, come take me go that place, where it is happening, where everybody dancing,